very much. Good afternoon, everybody. First, a few numbers as usual. When we look at testing, actually, my latest numbers are from yesterday in terms of testing. System-wide, we've tested 442,629 people, and the total positivity rate is 16.1%. If you look at just Baptist Memphis, we've tested 68,571, and the total positivity percentage is 10.2%. There's something interesting to be sort of extracted from that, I think, in that if you look system-wide, of course, we operate in multiple states with a large sector of both Mississippi and to a degree Arkansas. If you look at the Memphis percentage numbers, they've really not been greatly different, in just a little over 10% sort of range. But if you look at system-wide, if you take into account the very large increase in positivity in Arkansas and Mississippi particularly, unlike just Memphis alone, where things haven't really peaked at all yet, the system has actually gone up from 15.2 to 3% positivity all the way up to 16.1%. And that may not sound much, but it's actually a cumulative thing since we started this pandemic. So that's actually an impressive change in positivity rate when you think that that's just in the last month or two that change has occurred. So it really is emblematic of the great increase in percentages. And as people have heard, the positivity rate in this region is 20% of those who are being tested, when really an adequate rate of positivity of testing, I should say, is to get that positivity rate below 5%. If it's not 5% or below, you're not testing enough people. And obviously, there are a lot more people who are out there infected than we are catching. And that's part of the reason that this thing is smoldering on and really picking up speed right now. If we look at our hospitalization numbers for today, at Baptist Memphis, there are 79 people in acute care non-ICU beds and 32 people in the ICU. 21 of those 32 people are on ventilators. So that's for a total of 111 people now hospitalized with COVID-19 at Baptist Memphis. At Baptist DeSoto, there are 63 people in non-ICU acute care beds on the floors with COVID, and there are 12 people in the ICU with COVID at DeSoto for a total of 75 people there, and 7 of those 12 people are in the ICU. So the number is drifting up. I won't say slowly, it's been very rapidly although over the last week, it's not been an extraordinary increase. But it would have been difficult to imagine, a couple of months ago that we would be back over 100 people in the hospital and staying there. But certainly that's where we are right now. And as I say, we have a lot of transfers to this facility from surrounding areas, and so our ICU beds are really picking up with folks who are transferring here from outlying places. Certainly, as far as Missouri, for ECMO, the artificial lung sort of capacity, which we're the only people in this region who do it. And so we have a lot of requests for that, but frankly, there are a lot more requests than we have the capacity to bring in right now, even though we can expand our availability to a degree, to be sure. But we're getting calls from Louisiana, Missouri, and places that are a bit far flung because the places in those areas are all full, and they really don't have any more capacity to expand what they do. So hopefully, this is a situation that's probably going to be with us for a few weeks to come. So happy to answer any questions if there are any.
Hey, Doctor. Alex Coleman, News Channel.
Hi, Alex. How are you, sir?
Doing well. Thank you for asking. Just going back on the issue of hospitalizations, Arkansas this week hit a new record high, and Mississippi also on the verge of approaching a record number of hospitalizations. How concerned should we be about these numbers, and what are your concerns about the strain it could put on Memphis area hospitals?
Yeah, it's a very, very important situation. And basically, this is a back to the future sort of event here, and that we're back to really having to worry about the blunting the curve thing again. And people haven't had to think about or talk about that in a long time. There was a fairly compelling interview, or I guess press conference, that was done, I saw, from Louisiana. It was a physician named Catherine O'Neill in Louisiana, and she spoke, I thought, very eloquently about the problem and the degree of danger there is when hospitals and ICUs are overrun. To paraphrase and put it slightly differently, people, you may believe that this is not really a severe illness. You may believe that people aren't dying like people say they are. You may believe that people like us in healthcare aren't being sincere in what we're saying, but believe this. I mean, the numbers are impressive. And if you look at some of the projections for the Memphis area, some would say it'll be bad enough where all of the beds in this town are taken up. And that's saying something because we have a lot of beds per capita in Memphis and the area. And it just goes to show you that when you run out of those resources, now that situation is now back in play. And if you're talking about, you don't have to die of COVID to die of things related to car accident 6 weeks from now. You better take into account the fact that you could die in an ambulance because an ambulance wouldn't have any place to take you if those circumstances are accurate. And I hope they're not. I hope it falls short of that significantly. And we have as good a chance of anywhere of having as many beds available. But these sorts of things are scary, and that's kind of what we talked about in the very beginning of this pandemic. And thankfully, we're able to sort of abandon those concerns for a long time. But the cases are going up significantly, and they are if you look into our ICU and walk around, they are people who are very, very young comparatively, and those people, even when they don't survive, they will survive a lot longer. And those that means that there are a lot of beds that will stay occupied. And that means that you run out of them faster in that situation too. So that's a fear that we all have, not to mention just the strain on the healthcare workers, I think right now is extraordinary, maybe the highest that it's ever been. We've lost a couple of people in just one ICU in their 20s and 30s over the last few days. And Dr. Jeff Wright, one of our outstanding kind of critical care pulmonary doctors, did I think a social media post last night saying how much he appreciated the people on our ECMO team and the nurses and physicians involved in that because, it's hard. I mean, it really is. We've had some very difficult cases brought in from other places, and some have not done well. And for the nurses who have to be in those rooms, I've said it again and again, to face that sort of psychological strain right now. If people are sort of over this in the community at large to the point where they just don't care as much about it, well, these guys are over it too, but they still care about it, and they're still having to take care of folks that are very, very ill. So yeah, I am concerned about it, and I hope that the way to stop this is not to get infected yourself and not to give it to other people. So I think we as healthcare workers are very much out of patience with people who say this is not a real thing and we don't need to get vaccinated. The numbers are just too compelling now for anybody really to reasonably conclude such a thing. And the other thing is that we really don't want to have people getting unnecessary infections. I think that if you look at, just an example, the seatbelt analogy, I think, is the best thing that you can almost use to get this, to get this concept across to people. I mean, seatbelts, as I've said before, people sometimes die of wearing a seatbelt. They can't get out of a car in a situation like a fire. I've seen that happen, but you'd be very foolish to suggest that seatbelts are a bad thing in the aggregate and that it is statistically a dangerous thing to wear. That would be ridiculous based on the overwhelming data. And furthermore, seatbelts absolutely save lives, but you can overcome that. You can drive into stuff and you can still hurt yourself if you're not careful where you're going, even wearing a seatbelt. And if you drive into stuff fast enough, you can completely overwhelm that protection and die despite wearing a seatbelt of the thing that the seatbelt is supposed to protect you from. So if you're vaccinated, great. Everybody would support that, but don't wander around into super spreader events without a mask on in a poorly ventilated area. That protection can even be overcome. We have seen it, rarely, thankfully, but it still probably is something to be careful of. And all that feeds back into your question, Alex, of all those things serve to potentially overwhelm healthcare systems locally. Thankfully, we've not reached that point in the past. Thankfully, we are relatively protected against it just by virtue of the number of hospital beds we have in this city and in the near surrounding areas. But we are seeing it in other communities already, and it can be a very dangerous thing.
Thank you, Doctor.
You bet.
Hey, Dr. Threlkeld, it's Kelly with Channel 5.
Hi, Kelly.
Hey there. Two quick questions. One, I saw mentioned on today's email, kind of clarifying why we're seeing so many children being admitted into the hospital with COVID-19. And second, there have been a couple large organizations, one being SCS, that have implemented frequent testing programs. The SCS one is voluntary. Can you talk about the pros and cons of a program like that just provides frequent testing to those who choose? Thanks.
Yeah, you bet. And so, I mean, several things there. I mean, just what is going on with the kids. This is, I mean, we're in something of a, if not a perfect storm, a very good storm, in that two things are going on. Number one, we're facing a much more contagious virus than we were facing a few months ago, even as we were doing so well. I mean, things were going quite well, and we were pulling back on our precautions and feeling very good about the situation. But that, unfortunately, is part two. We are not of a mind to protect ourselves anymore because we're no longer afraid of this. Even as the Delta variant was sort of swarming through the UK and India and other places, that's the same time we were doing well, and we really weren't paying probably enough attention to what was going on in other parts of the world. It's not the first time during this pandemic that we've seen that. So we had this very bad juxtaposition of two things. I mean, first is the fact that it is a much more difficult virus to contain. It's much more contagious. It spreads clearly very well among kids. And then we have a situation where we just don't care as much about it, and we're not as inclined to take those protective measures. Masks, for example, have become an incredibly politicized situation. If you look at the numbers on masks, before we even talk about testing, they do work. I mean, there's just no question that if you compare school districts, there's some large studies that some of the folks in North Carolina have been looking at. They found that schools with mandatory masks just did very well and had a very low transmission of virus among the kids. You look at the studies that went back to Wisconsin and others into the last school year, and we found that there was a remarkably low transmission of virus among school kids in the classroom. But again, it presupposed adequate masking on everybody, reasonable separation, which can be difficult in some schools. And again, the most important thing, it wasn't the Delta variant that we were dealing with. So how much does the Delta variant then overcome that protection from the other two factors? Because we can't control that factor anymore. It's gone now because the Delta variant is here. But we certainly can still control masking and some separation. I think the data would suggest that those things do work. And it's already showing in some of the school districts that have not done any masking, or even mask optional for that matter, they've had a large number of cases and therefore quarantines, and therefore the threat of shutting things back. So I think that most people in infectious disease, and certainly epidemiology, would argue that as we're going through this spike of the Delta variant, the safer maneuver is to utilize masks, because the data are really that they work fairly well. Are they perfect? No. But if you put the mask on someone with COVID and a mask on someone near them who doesn't have COVID, the combination of those things clearly cuts down on the transmission. So we have to be careful, because I think I've heard a lot that, well, this is going to be a short-lived peak. And we think that is true. We hope that's true. It's what we have seen to a degree in India, in the UK, and even a little bit in the states of Missouri and others that are experiencing such a bad time with this. But if that's your plan A and your plan B is that this may not last very long, that's not a very good plan. And so we have to look at other things. And that then finally, to your question, when we look at testing and those strategies, that's the other way. It's the other layer of the protection. We've learned pretty well that multi-layered protection is what you need in a lot of things to be safe, and this is certainly no exception. If you're wearing masks, that's going to cut down on the transmission. If the kids are vaccinated, which we can only do at 12 and over right now, so it doesn't help in elementary schools, but for middle school and high school, it can be the effective strategy. That's going to help tremendously. But then finally, the third strategy is finding out where the thing is and get somebody who has active disease into isolation or quarantine if they're at high risk of getting it from a contact. So it's just one more strategy, I think most people would agree, at preventing large outbreaks. And that large outbreaks in these schools are going to unfortunately temporarily get us back to the situation where people debate over whether it's safe to be there at all. And everybody agrees that it's the best thing for the kids to be in school. So why not, for a month or 6 weeks or whatever this kind of duration of the problem exists, be more careful if we're there so we can get them there. So I think targeted testing has always been an important strategy. And as I mentioned a minute before, it's really clear that we're not testing enough right now, because when you're talking about a 20% positivity rate, there are a lot of people out there who are positive and not being tested, and therefore transmitting it to other people. And that's complicated further by the fact that the vaccine, though terrific at preventing serious illness and death, is not as effective with the Delta variant as it was with ones before. There's a little resistance out there that's creeping into play, and so it allows for more infections that don't make you terribly ill, mind you, but they're there, and then they can transmit to others. And so that's what we need to sort of turn off that. And we need people to pay attention to their symptoms, particularly if they've been vaccinated. If you have a sinus infection all of a sudden and you've been vaccinated, you need to be very careful that that's not COVID. And you probably should be tested when in doubt, because there can be mild symptoms and even no symptoms at all. And so even targeted testing among asymptomatic people is not a crazy idea at this point. It's just difficult, I think, to execute right now.
Hey, it's Corinne. How are you?
I'm good, Corinne. How are you?
I'm doing pretty well. To follow up on that, there has been kind of some change in guidance from the CDC about how people who are vaccinated and come in contact with someone who is COVID positive need to react. Before it was, they don't need to isolate. Now there's kind of a recommendation of getting tested after 3 to 5 days. Can you explain a little bit what people who are vaccinated who come in contact with someone with COVID should be doing right now?
Yeah, it's a great question, and it's one that's, I feel for the CDC. We can all agree there have been times when the CDC messaging has not been adequate and been a little confusing from time to time. They're in a very difficult situation right now because the data that we have that they have been utilizing for past recommendations were non-Delta data. And so Delta has changed matters. You're just dealing with a virus that behaves very differently and much more aggressively at transmission. So I think they simply are reacting to the fact that if you are around someone with COVID, you are now more likely to come down with maybe an asymptomatic infection, but an infection. And though you're not likely to get ill, as we keep saying, and we try to sort of keep saying that because people can cloud that issue sometimes in their claims. But even though you might not become ill, you might be fairly effective still at passing it to others. So if you're vaccinated and you come around a clear, let's say, household contact, the data for Delta would suggest that you're much less likely to escape that infection if you live with someone who is infected with the Delta variant than you were to have escaped it from the Alpha or the Wuhan variant. It used to be that we would put people in their bedrooms and slide food under the door and the rest of the household might come out unscathed. That's a lot less likely this time. So what we don't want to have happen is people then, because they're vaccinated, presume that they're not only going to be safe, but they're also going to be completely uninfected. Those people then may have a little sniffle and not think much about it, or maybe even be asymptomatic, and then they go to school or work, and all of a sudden with the R0 value of this virus, one person doing that can infect 8 or 9 other people a lot more easily than we saw before. So the time is very much right to be very careful to make sure that you don't have the infection. So it is reasonable, I think, the latest recommendation to go ahead and get screened at 4 or 5 days after the exposure, because most people, as we all know now, are going to get infected in that relatively short period. It can be out to 14 days, but that's a very small percentage that take that long to transmit or to incubate. So the better part of valor, I think, is to screen to make sure that you've not been asymptomatically infected and just aren't putting a lot of other people at risk, because there are people in that risk pool who might be unvaccinated or vaccinated but immunosuppressed and unable to generate adequate immunity, or maybe even someone that gets a really big dose or inoculum of the virus despite vaccination, and say an elderly person that even that immunity that normally would be good could be overcome just by the circumstances. So it's very reasonable, I think, to do some of that screening, even if asymptomatic, if you have had a close exposure, because that close exposure is much more likely to get to you in the form of an infection with Delta than it has been before. Any other questions? There are several questions, and I'll try to answer a couple of them from the feed last week, and at a week apart, some of the questions sort of move on to different ones. But Kelly Gimin, I hope I said it right. What would you say to doctors and nurses who have refused the vaccine and in fact are telling their patients not to take it? I will resist the less politically correct answer to that and say that it's worth having a discussion with them. I think that in almost every circumstance, they are incorrect. And I think that it would be helpful to ask them for the data that they are utilizing. I do encounter this sometimes. I have talked to some of those folks, and occasionally that's a productive talk. Sometimes it's not, but there aren't many people who say that. And I think you need to be very careful what doctors and nurses are saying that. Do they really know anything about COVID-19? Do they have any experience with COVID-19? I will give the example of the gentleman in Indiana who gave a now famous talk to an Indiana school board and went off on sort of a 10-minute discussion about why vaccines are ineffective and a number of things, saying the CDC and the NIH recommendations were wrong. He's a family physician who passed himself off as like functional medicine, which and then went off and talked about, for example, he made a number of claims that all of the recommendations were false and incorrect, and then he spoke of his own experience. And he said, I personally have treated 15 patients with COVID-19 with ivermectin and vitamins and minerals and so forth, and they all did fine. And that was his argument. I mean, I've seen 15 patients this morning with COVID-19, and for somebody to stand up in a microphone and sort of get that sort of publicity by saying he had treated 15 patients, that's just an admission flatly and black and white that he doesn't know much at all about COVID-19. And he certainly has not created a study in 15 people who are non-blinded, non-controlled trial, when 15 people randomly in the community are almost likely all to do well anyway, particularly if they're younger, healthier people, with or without ivermectin or anything else. So again, I would just argue that you need to know what the experience and expertise is of the people that you're talking to, and compare that to the people who are saying the alternative, which is almost everybody in the field who knows anything about the data. Slightly harsh, but it is certainly the way I feel about it. This is Cindy Garrison points out that our friend is in the ICU with COVID and was vaccinated. So to say everyone in the ICU is unvaccinated isn't true. I would not say that everyone in any ICU is never vaccinated. I have had someone die, as I have said before, who had been vaccinated. So it can happen, but I would say is the dramatic exception. I've only seen that once. And what I actually said, I think, was that everybody in our ICU right now at that point last week was unvaccinated. And I think that is true. You will see it, but it is extraordinarily uncommon. If you look at the data around the country, you're 8 times less likely to get any symptomatic infection if you're vaccinated, and you're over 25 times less likely to die and go to the ICU if you've been vaccinated. So it does happen, but it is extremely rare. And very frankly, I think one of two things is almost always at work when it does happen. You're either immunosuppressed, and I've had one of those too, in case the vaccine really didn't work very well and didn't have a chance on it. So that person is nearly functionally unvaccinated despite trying their best to get the vaccine to do the job. And then the other one is somebody who had a very, very large inoculum and may have overcome that vaccine. So it happens, but again, it's like that seatbelt thing. To suggest that vaccines are not dramatically effective because you find one person in one hospital that died after vaccination is just not a reasonable statistical inference to make, I think. Ms. Mant said, he said, if we get vaccinated, it will go away. Please stop lying. I don't think it's going to go away. I'm not sure that anyone ever said that. I think that many of the, or most all of the deaths will go away if everybody gets vaccinated, barring another variant that comes along. It could, but then again, the best way to avoid that from happening is to get vaccinated also in the first place. So I think a lot of people would agree that coronavirus may be here to stay in a less virulent form from time to time, more similar to the flu. We don't know, but certainly, once again, a lot of these points are just distractions from the fact that the vaccine is the overwhelmingly safe and effective way to make this as small a problem as we can make it and to stop the deaths out there. Marty Burke asks, are vaccinated people vectors? Absolutely, as we mentioned, because of some creeping resistance of the virus. It's not as effective at preventing total infection, though still pretty effective. Many people don't get infected at all and are not symptomatic just because of the vaccine. But it has a higher ability to break through just that far. And there have been questions about whether the Moderna or the Pfizer is the better vaccine for the Delta variant. There's been a fair amount of press on that in the last couple of days. Moderna seemed to, on a yet unpeer-reviewed study, a couple said that Moderna is more effective at preventing symptomatic disease than is Pfizer. I got the Pfizer. I have no real need to go out and get a Moderna on top of that right now because of two things. I think they're both still and relatively equally effective at preventing the severe infections, the type that lands us with an illness that gets in the hospital or results in death. So I think they're both, even in those data that are listed, are suggested to be about the same. And secondly, this may be reversed when the next variant comes along, even if it's found to be true, and it hasn't really been yet, I think, to statistical satisfaction and peer review. But even if that's true, we saw the Israeli data suggesting that the Pfizer vaccine was much less effective than before with previous variants at preventing any infection whatsoever. So even if that's true, the next variant may be reversed. It's important to point out that the Delta variant did not arise from the Gamma, did not arise from the Beta, did not arise from Wuhan. These are all independent changes that branched off not down the line sequentially, but they arose independently. So it's not necessarily the case that that the next variant that we see is going to have all the same characteristics from the ones before. So it may be, even if true, that you may find the reverse in the next variant. G. Cole Jackson said, scared to not and scared to take it. It's a toss. I've had reactions to injections. I think that's well put. I think a lot of people feel that way. And I think it's reasonable to be scared to take the vaccine and not to be scared to take the vaccine. But if you really put pen to paper and look at the numbers, you will find out that you should be much, much, much more scared not to take the vaccine. It's a matter of understanding the relative risks. And I've said many times that our brains and the way the human mind psychologically works, we don't do a good job at comparing low risks to ourselves. But if you really look at the numbers and ask people that you trust, it is such a difference that it is the small amount of fear from taking any medication or vaccine truly pales in comparison to the risk of this infection. Look at the 600 some odd thousand dead already just in the United States. I don't know of anyone who's seen anyone die from the vaccine. I don't doubt that it's happened. I just haven't seen it or seen anyone or heard of anyone in medicine that I know who's ever seen it happen. Michael Mack asked how many of the patients had been vaccinated. Do we have those numbers? It's a good question. I would say that that finding out total vaccination rates is a little bit difficult. We can tell you how many people are vaccinated at our own facility, but it has to be a verbal question to someone. It's a little harder to collate about who had gotten vaccinated with what when. But suffice it to say that the numbers remain dramatic. The people in the ICU have not been vaccinated. And then finally, Trish Cole asked, when being tested positive for COVID, why can't they tell us what strain we have? They can, but it takes an additional test. So the COVID test itself is a PCR that just shows that you have the RNA in you or in your nose from COVID-19. It takes a different extra test to tell you whether you have the alpha or the delta variant. It's a little test that adds the sequencing to that so you can tell which gene mutations there are that are characteristic of those variants. So it's an extra test, one that we do less and less now because essentially everybody that we're seeing has the Delta variant when we do the test. And secondly, and importantly, we don't do anything different for someone who has a Delta variant from someone taking care of them from someone who has the Alpha variant. The treatment would be the same. It's really more of an observation tool to know what is in our community. So for example, if the Gamma variant or even the Lambda variant that's in the neighborhood, if it starts to be a larger proportion, we need to know that for epidemiologic purposes and for public health sorts of issues. So the city and county, it probably is, is good for them to screen these things, although on an individual patient level, it would not make any difference to you other than realizing that you're more contagious to others. And by now, you should really count on that in the first place and be very careful about it. So thanks for those questions. I appreciate it. Any other questions I can answer? Okay, thanks everybody. Have a great weekend.